Well, good afternoon. It's a real great pleasure to see so many of you here, and it's also an enormous pleasure to introduce my longtime friend and colleague, Chris Dye. Now, I was trying to think how long I've known Chris Dye, and I can certainly remember standing in a drinks reception with him, each of us with a very small baby on our hip, and those babies are in the second half of their 20s now, getting quite grown up. So I've known Chris more than half of my working life. Chris started out with a similar sort of job to me, an academic epidemiologist and modeller, and then he did this incredibly, I think, brave and important thing, which was that he decided to put his money where his mouth was and go and work at the World Health Organization in Geneva. He did a lot of very important things there, for which the world is very grateful, actually. And he's now stopped doing that and is back here this year in Oxford as a visiting fellow at All Souls, taking some time to reflect on this long time spent working in global public health. He's come up with this question, which is what he's going to talk to us about now. And in order to leave as much time as possible that we can listen to Chris, I'm going to step down and introduce this evening's speaker, Chris Dye.
Thank you very much, Angela, for that introduction. The audience should know that the word brave is also a euphemism for silly in our business as well. But thank you, Angela. It's great to be here. Prevention is better than cure. That must be a truth because we've been saying that for more than 2,000 years. But if we have been saying it for 2,000 years, how come we spend so little? How come we invest so little in staying healthy? And that's the question that I want to address in this talk. But you might also like to know why I'm interested in that question as well. And the reason essentially is here on this slide. I've been going around the world for the last few decades encountering scenes like this one on the right. This is open defecation, which is commonplace still in parts of India. This is a way of propagating diarrheal diseases. It leads to malnutrition in young children. It leads to stunted growth, poor performance at school, and all the rest of it. It clearly is a major health hazard. And yet, we've known how to do sanitation for 4,000 years. I picked the photograph on the left, which is an archaeological site in the Indus Valley at a place called Harappa, now in Pakistan. This is an excavation of a sanitation system at this site, and what's interesting about it is that this sanitation system is not just personal facilities for wealthy people, it's actually community-based sanitation system. So when you do the archaeology, you're unearthing the technology around sanitation, but you're also discovering a social system that protected people's health as well. And I'll come back to that much later in this presentation. But the question is there. You know, there are 7 to 8 billion people on the planet at the moment, and more than 4 billion people still don't have access to safe sanitation. Why is that? That is fundamentally a question that interests me. Now, the question of prevention over cure has been discussed for a very long time. I say here 2,000 years of philosophy. You probably recognize the person on the right. That's Matt Hancock, the current Secretary of State for Health in the UK. Let me tell you a little story about the person on the left. He is Asclepiades, a well-known Roman Greek medic who was extremely keen on prevention. He was a strong early advocate for prevention. In fact, he was such a strong advocate that he decided to stake his reputation on prevention by making a bet with the goddess Fortune that if ever he became ill himself during his lifetime, he would forfeit his reputation. Now, he's said to have died age 84 by falling down the stairs, thus avoiding terminal illness and winning his bet posthumously. The story of prevention runs from then, in the literature, in the written literature, from then until now. Matt Hancock, so far as I know, is alive still today, and I'll say a little bit more about him in a moment. Now, as is usual in this long written literature, nothing much happened for about 1,000 years after the Roman Greek period. So if any of you are experts in the Middle Ages, please forgive me for this rather simplistic statement. But essentially, this is what you read on this slide as an illustration of that. Back in the 1st century AD, Perseus was saying, for example, we should meet the malady on its way. That's a way of saying that prevention is better than cure. But more than 1,000 years later, you had Bracton in his celebrated De Legibus on the customs, laws and habits of the people of England. Better to meet a problem in time than to seek a remedy after the damage is done. Essentially saying the same thing more than a millennium later. And through the Middle Ages, there was a very strong emphasis on prevention. And you can understand why. This was a period of time where even the slightest infection could be fatal. So if there were a way of preventing illness, there would be a strong premium on that, especially for those who could pay the money to do it. And what the medieval physician was charged with was so-called regulating the non-naturals. And this has a very contemporary feel about it, to me anyway. If you read this literature, it's about diet, exercise, rest, environment, mental well-being, all the things that you read about in a newspaper on a daily basis today. But there are a couple of other important things about this which make it even more contemporary. One of them is the recognition that the so-called complexion of individuals differed from one person to another. So ideally, patients needed individual attention, and this is what we now call personalized or precision medicine. And that wasn't invented in the 21st century. That was being discussed in the Middle Ages. And the other facet of this is that this wasn't just about individual healthcare. This was actually being applied to groups and subgroups in the population. In other words, this was fundamentally public health being done in the Middle Ages. Now, a little bit later on, Erasmus, the humanist, a bit of a magpie with respect to collecting things, gathered together all of the sayings, aphorisms, maxims that he thought was important around about 1500 in his book of Proverbs, the so-called adagia. And when you read about Erasmus's work, you'll see that he's often credited with a statement that prevention is better than cure. He included this in his book. In fact, on a closer look, he didn't quite say this. He said something which is less suitable, less ideal to real preventionists. He said what's written in the middle there, which is better to treat at the beginning of illness than at the end. And this is a very contemporary debate here in the UK at the moment, where there is great concern about whether Matt Hancock, the Secretary of State for Health, when he speaks about prevention, he's really concerned about true, deep, proper prevention, or whether he's concerned with early diagnosis. There's a really important difference between the two. And that difference, that important difference, was not made clear in the translations of the work of Erasmus. A little bit later on the 1700s, Benjamin Franklin, who was a genius by anybody's standards, made some extraordinarily important contributions to this discussion. He's credited with the statement that an ounce of prevention is worth a pound of cure. Now, the ounce and the pound are not to be taken seriously, but what is interesting is the inference that one is going to weigh the costs and benefits of prevention against the costs and benefits of cure. So for the first time, the way this story is being told, it's being told in a potentially conditional way. Prevention absolutely is not better than cure. Prevention conditionally, potentially, is better than cure. The other thing that Franklin did is, because he was concerned with actually fire safety, although this phrase of his, an ounce of prevention, has been widely abstracted and used in other circumstances, he was primarily interested in fire safety. And he realized that there was a large population at risk, but very few people would suffer a fire and be at high and devastating risk. And so he was concerned about how you would spend the ounce and get the prevention of cure. And of course, what he came up with at the time was essentially an early insurance system. In other words, he realized that what you would have to do, threatened by something like fire, is that you would have to share the risk. And in 1751, he founded the so-called Philadelphia Contributorship for the insurance of houses by loss of fire. So he recognized that what you were dealing with in prevention is risk and uncertainty and the management of risk and uncertainty. Let me jump forward to time present, and the main philosophy for development, at least as told by the United Nations at the moment where I used to work, the World Health Organization, the Sustainable Development Goals, essentially the world's development framework at the moment. And the Sustainable Development Goals are an umbrella for all sorts of upwellings and uprisings of different ideas about health. Some of them are listed on the left. One Health, Health for All, Planetary Health, Universal Health Coverage. All of these things are included in the Sustainable Development Goals. You normally see the SDGs represented by that circle, bottom left, but I've drawn them in a different way in the middle here. I've put health in the middle, SDG 3, surrounded it by all the others, because very clearly all those other things contribute to good health, and health contributes to those other things. So the fundamental proposition of the Sustainable Development Goals is that we must look harder at the root causes of ill health. In other words, we must think harder about prevention. So the world of health does many, many things in this green box in the middle here. This is all about healthcare, but fundamentally we need to look at the root causes. And you'll see, if you trace the origins of the Sustainable Development Goals, those of you who are interested in the environment will know about the Rio Declaration in 1992, which includes very strong prevention in the form of the precautionary principle. In other words, if there's doubt, if there's risk or uncertainty, then act. Don't not act, actually act. And the precautionary principle is a very strong statement about prevention. So let me summarize, against that rather brief background, let me summarize the dilemma of prevention. About $7 trillion is spent on health each year. So there's about 7 billion people on the planet, so that's about $1,000 per individual, but rather unevenly distributed, of course. But it's unevenly distributed in a number of ways. And particularly, I want to draw your attention to the difference between these two numbers at the top. Of that $7 trillion, about 96% is spent on treatment and medical care, and about 4% is spent on prevention. That is a very small amount of money being invested in prevention indeed. That's as against the preventable causes of death, which you see down the left-hand side. And here I've grouped them into three groups, as is traditionally done in the public health field. Environmental causes, which preventable deaths, more than 17%, at least 17%. My colleagues in WHO would say more than 17%, 20 to 25%. Metabolic disorders like diabetes, and behavioral aspects, for example, smoking, alcohol, diet, exercise. And I put the behavior in inverted commas there because we usually think immediately about the behavior of smokers, but we must also think about the behavior of tobacco companies and about governments as intermediaries between people and tobacco companies. And you can see if you glance at the pictures, let's just take the top one for the sake of interest. Here's the failure of sanitation. This is a young child being treated for cholera. So you can treat young children for cholera, rehydration, you can potentially save their lives, but why not prevent cholera in the first place by investing in prevention? And that's essentially the story that's being told throughout these pictures here. And alongside those statistics, we find in the health economics literature an enormous volume of material that tells us that we should invest in prevention because the return on investment is very high. So these data, I could have picked many, many sources of data. These come from the so-called Prevention Institute in the United States. What they look at is the return on investment. In other words, $1 invested in any of these things to do with prevention, government level, community level, clinic level, including fluoride in the water, breastfeeding support, tobacco control, vaccinating children. The calculated savings are far greater than the $1 invested. So the message from this is, look at all of these savings that we can make from investing in prevention. And yet, people don't invest in prevention, apparently. Why is that not so? And when you read the economics literature, you'll often see this referred to as a false economy. In other words, we economists are telling you that if you don't invest in prevention, it's a false economy. My view is different, actually, and that difference of view underpins everything else I'm going to say in this talk. And that is that, in my view, what people actually do is quite rational under many circumstances. They just have a different perspective. They have different values. They're attempting to solve a different problem from the question being addressed by economists. So, what does prevention better than cure actually mean? Put very simply, under the best of circumstances, it's an aspiration to good health. And of course, most people in the world want to stay healthy. They want to prevent illness and disease. But when it comes to the crunch, they're not going to do that at any cost. So the real truth of the matter is that investment in prevention is conditional, as suggested by Benjamin Franklin and a number of others who have followed him. And it's that conditionality that I want to explore in the rest of this talk. So here's how I'm going to explore it. I'm not going to do something very quantitative and very numerate, but the concepts here are going to lie behind everything I'm going to tell you in the rest of the talk. So we're looking at the relationship between costs and benefits. And clearly, prevention is going to be favoured if the costs of doing so are low and the benefits of doing so are relatively high. Absolutely or relatively high. So the costs and benefits, they could be monetary or non-monetary. And the benefits really have these three important constituents. If you're doing a formal economic analysis, the benefits often stop at this point here, an objective measure of the value of investing in prevention. So this might be simply deaths, or it could be what are called QALYs in the health business, quality adjusted life years, or DALYs, or preventable, or the value of preventable deaths. There are various objective measures that can be used. What's important is that the value of these measures is going to be high right now, and it's going to fall away into the future. If those benefits come a long time in the future, you will discount them by time. The second element of this is uncertainty. What we're doing is investing in prevention. We're investing to prevent something that we're not certain whether or not it will happen. So if you have something that's extremely high value in the future, in other words, a really big threat, but there's a very low chance of it happening, then you're unlikely to spend the money. And that's what I mean by P less than 1 there. And then finally, the third important thing is whatever those calculations come out as, you as an individual, either acting in an individual sense or in an organizational sense, will have a personal value about how you want to assess those costs versus benefits. And I'm calling that utility here, which goes beyond the way in which utility is normally used in economics, but essentially this is the subjective value applied to the results of these calculations. And what I'm interested in here is what economists often call positive economics, in other words, an investigation of the way things are, as distinct from normative economics, a prescription of how they should be. And in my experience, over the last 2 or 3 decades, the public health literature is crammed full of normative assessments of the way in which people should behave, such as returns on investment, and there's relatively little positive economics, in other words, an evaluation of the way things are, a study of how people actually make choices right now and the reasons why they do that. And that's what I want to see more investigations of. And my null hypothesis, if you like, at the bottom, is that the choices that many people make much of the time are not irrational, they're not a false economy, they are actually quite rational if you understand the circumstances under which they're made. Now I'm going to get into choice made by people, but I was originally a zoologist, as Angela said, and I can't risk this, I have to include this very brief digression here, lest you think that the problem of prevention and cure was first contemplated by Greek philosophers. Animals, you know, self-medicate, and they also group-medicate, from ants to relatively high primates. And the question, therefore, is do we use our medication in a preventive sense or in a curative sense. This is a wood ant, and this is a nest of the wood ant, which is just above my house in the Jura, in France, where I normally live. And these ants actually use pine resin as an antifungal and an antibacterial agent. And some very neat experiments that have been done in a Swiss lab showed that these ants use the resin prophylactically, not for treatment. In other words, this is prevention, not cure. Anyway, enough of zoology. Let me get back to the way people make decisions. And I'm going to just tell you 5 short stories. The first is about health services, then about vaccines, then emergencies, climate change, and finally water and sanitation, where I started. So, back to Matt Hancock and the National Health Service. The question's been asked in recent years, is this a National Health Service or is this actually a National Sickness Service? If it's a National Health Service, then we should really be investing more in prevention. And this paper put out by Hancock's department in November 2018 was a precursor to the NHS long-term plan that you may have heard of that was released earlier this year. And the signs in this paper are very positive. Our vision is to help you live well for longer. Prevention will be embedded into every part of the NHS over the next decade. State, society, business, and people. Sounds fantastic. I'll say a bit more about the NHS in a moment, but let me put the UK in broader context, because what the UK is doing at the moment, and I'm going to be slightly critical of it, is actually not so very different from what many other countries are doing. So these are all the countries in the OECD, and what this picture shows you is, in the bars, per capita investment in health, and you can see that's highly variable from Canada on the extreme left, the highest investment per capita, to Latvia on the right. And the variation in health spending per capita changes by a factor of 10. The dots on this graph are the percentage of that investment per capita that is devoted to prevention in the way that I described before. And you can see that there is variation among these dots, and they refer to the right-hand axis here. There is some variation, but most of that investment is between 2% and 4% of spending per capita. Relatively tightly bounded. So it doesn't matter very much how much people spend in different countries per capita on health. What the proportion of that devoted to prevention is relatively constant. But it's not completely constant, and it is subjected to various pressures. But before I show you what those pressures are, there's one important thing that I want to point out here very briefly, and that is that all of these statistics on health come from SHA, in other words, the International System of Health Accounts, which counts only the money that is directly spent with a primary purpose of improving health. And there's a problem with that in the context, for example, of the Sustainable Development Goals, which I suggested were about understanding root causes. So many of the things in the Sustainable Development Agenda, investment in energy or transport or education or environment, have the primary purpose not as health, but with indirect benefits for health. None of that is counted in the system of health accounts, and actually none of it is systematically counted at all at the moment. So it's a big gap in the database that we have to work with. But let me show you what happens when you put pressure on a health service. And what happens when you put pressure on a health service is not different in the UK from other countries in the OECD. So let's use the word austerity here. When this is OECD data from about 2005 and 6, and it leads up to the financial crisis of 2008 and then the recovery period up to 2015 here. So first of all, GDP, this is growth on the left-hand axis. This is not absolute values, but growth. You can see that in the 2008 crisis, growth in GDP really fell dramatically and became negative across all of the OECD countries. The thick grey line here is total investment in health, which suffered a bit, but not very much. What really suffered was investment in prevention. You can see there's a collapse in investment in prevention, growth went negative, and it took many years to recover. So wherever you see pressure on health services, not just in the UK, the prevention budget is going to get squeezed. And that says something about the consequences of head-to-head competition between prevention and cure in a health service. These are the latest figures for the NHS in light of the statements that have been made by Matt Hancock and others about continuing to invest in prevention. In fact, just look at the red bars. This is investment in prevention in the core public health grant. You can see there's been a decline year on year on year, so that over the last 5 years, there's been a 25% reduction in budget for prevention. And it's actually worse than these statistics suggest for reasons that I won't go into in this talk. But what's being said at the moment about prevention is not being matched by investment. And frankly, given what you see in many countries around the world, you wouldn't necessarily expect it to. As I've said, when you have a head-to-head encounter between money spent on prevention, things for the long term and the future, it's not going to do well when you have to sacrifice budget for immediate treatment and cure. And that is a message from the NHS, and it's a message across OECD countries. So what should we do in consequence for that? Where are the positive messages that come out of this? Well, of course, we need to go on arguing for investment in prevention in the National Health Service, but we also have to be clever about other potential sources of investment. And there are many possibilities here, but just to touch on first one and then briefly another one, if you're talking about prevention of tobacco, in other words, stopping people smoking, you can invest in tobacco prevention programs, but the best way of doing it is actually punish people in their wallets. If you increase the price of cigarettes, then people stop smoking. It's very clear indeed. I've taken these data from a 2014 review by Prabhat Jha and Richard Pito, France at the top, South Africa at the bottom. This shows you, the black line shows you consumption increases. This is the price. When price starts increasing after the early 1990s, then consumption falls. And exactly the same happens in South Africa, and it happens in every country in the world in which you do it. So you can try and persuade people to stop smoking, you can try and allocate budget to that, but the best way to stop people smoking is actually raise the price of cigarettes through taxation. And actually that's government revenue as well. So what I'm saying in part is, rather than going head-to-head in competition, try and avoid the competition and raise the funds from somewhere else. And just by the way, on smoking, and the way in which choices are made, we have to distinguish in an important economic sense between capital in terms of money and political capital. You see, in the UK, smoking on the London Underground system was only finally banned in 1987 after the King's Cross fire. There was a movement to ban smoking, but there was resistance to it. What the government needed to get across the threshold, in other words, public consent, was a major fire in a major railway station, and then you could push the law to its limits. Then you could make the decision. Now, if you want to know how governments make choices, the people are making the choices, you need to do the standard economic analyses, but you need to understand how political capital is being spent as well as monetary capital. So let me move on to the second theme, which is vaccines. And the first thing I want to say is that the premium on vaccination is extremely high when it comes to elimination and eradication. So the public perception of the value of eradication from vaccination is much higher, I think, than economic calculations suggest. So this is good news if you want to try and vaccinate a disease. So on the left is smallpox, which was eradicated by 1977 at a cost of only $125 million then. Of course, it would be worth more now, but it's a relatively small sum of money for smallpox eradication. The next disease to be eradicated will probably be polio. We're down to just 2 countries now, Afghanistan and Pakistan, and just a few cases in those countries. The cost of polio is far, far, far greater. And the argument about eradication has wobbled backwards and forwards. But at the moment, it seems pretty robust. The 20-year plan from 2013 to 2033 is said to cost between $10 and $16 billion. That's far, far higher than the cost of smallpox eradication. But the donors and everybody else are willing to go along with that at the moment because polio eradication would be a huge boost, not just for polio, but for public health worldwide. That said, so that's a question of how value is attached to a result in health, which you have to understand. That said, by far the greatest benefits from vaccination have actually come from the expanded program on immunization, which is a successor to smallpox eradication in the 1970s. So this was the idea that all young children will be vaccinated against diphtheria, whooping cough, tetanus, tuberculosis, measles, and so on. And the budget for the expanded program of immunization lies within the 4%, if you like, that I've been talking about, and it has without doubt saved millions and millions of lives of children. But I want to say a little bit about the incentives in industry for investing in new vaccines. The complaint is often heard that pharmaceutical industry is very interested in drugs, but why aren't they interested more in prevention, such as developing vaccines? Well, there are a number of very good arguments from the perspective of the pharmaceutical industry why they're not, and I'll just show you one of them here. The graph that you see in this picture is the distribution of disease risk in a population. So it varies from one disease to another, but basically it's this form. It's a power law typically. So in other words, you have lots of people at low risk and very few people at high risk. So the risk distribution follows a curve that looks something like this. Now, if you're making a drug, you can treat anybody under the curve. You know all of those people, the people at low risk and the people at high risk, who end up getting disease. But if you're making a vaccine, you've got a difficult choice to make. You've got to choose whether you're going to make a vaccine that's suitable at low cost for a large number of people or at high cost for a much smaller number of people. In other words, you haven't got the whole area under this curve. What you have to decide is, are you going to vaccinate all these people down here at low cost or all these people up here at high cost? Now, if this curve is a so-called even revenue curve, a ZIP curve, it actually doesn't make any difference what choice you make. You're dealing with this sort of square here, and if you drag it that way or you drag it that way, it doesn't make much difference. The area of that square is just about the same. So if you're a vaccine maker, you can decide to make a low-cost vaccine for everybody or a high-cost vaccine for those few people at risk. But whatever you try to do, the revenue that you're going to get from making a drug is basically higher than the revenue that you're going to get from making a vaccine. And calculations of this, for example, on HIV risk in the United States suggest that in general the drug revenue will be about 4 times the vaccine revenue. So pharmaceutical companies know this, and this is why the drug market is worth about $1 trillion a year, 930 billion at the latest count, but the vaccine market is only worth about $60 billion a year. And on top of that, in terms of vaccine manufacture, there are clearly some easier targets and some more difficult targets. For a long time, and this is a particular business I've worked in, we've wanted a vaccine for HIV, malaria, or tuberculosis. But it's very clear that the science is much harder to make a vaccine of that kind than it is for diseases like measles or even Ebola that I will come to in a moment. And by one recent assessment, we're not going to have a vaccine for these things unless we roughly triple research spending over the next period of time from something like $3 billion a year to getting on for $9 billion a year. So there are very good reasons why the pharmaceutical industry doesn't invest in vaccines, and those are just 2 of them. Let me say a little bit more about Ebola, because I was involved in the West African outbreak, very closely involved in the West African outbreak. The vaccine success story for Ebola was a terrific one for investment in vaccines and for protecting people in low-income countries against infectious diseases. And I was actually one of the people that was involved in the first Ebola vaccine trial, and my antibodies against Ebola are still being monitored on an annual basis. The problem post-Ebola, what happened during the Ebola outbreak was that there was a precursor vaccine on the shelf. It was taken to a product and it was actually tested within the course of the epidemic itself, and it was tested successfully. But the question in reflection after the Ebola epidemic was over was, why didn't we have a vaccine for Ebola anyway? In fact, why didn't we have a vaccine for Ebola or Lassa fever or Nipah virus or MERS or chikungunya or Zika virus or all of these threatening viruses that have emerged since? And so a concerted effort has been made since the Ebola outbreak to try to increase the incentives for investing in making these vaccines. And one of the major initiatives is called CEPI, the Coalition for Epidemic Preparedness of Innovations. And their banner headline really says it all: a global insurance policy to defend against future epidemics. And what I'm saying about the principles of investing in prevention, insurance policy is exactly the right terminology. So what you need to do is to manage the risk. An individual pharmaceutical company doesn't want to invest in one disease like, say, Lassa fever, which will only affect a small number of people in a country where people can't afford to pay for it anyway. So getting together, what you can do, and this is what CEPI has been doing, is manage that risk productively. And they've done at least 3 things that are not mutually exclusive. First of all, put all of these diseases together as a portfolio. Don't think about one at a time. Think about them as a collection of infectious diseases that we want to protect the world from. Secondly, think not necessarily about the specific vaccines that you would deliver for Ebola or Lassa or Nipah or whatever it might be, but let's think about the generic precursor technologies that would protect, or at least these would be the root protecting devices against whatever disease happened to emerge. Against, as WHO has called it recently, so-called disease X. And the third thing is pool your money so that you as an individual investor are not entirely at risk and alone. Pool your money. So these international initiatives stimulated by the Ebola outbreak mean that there is now stronger investment in prevention of these diseases rather than responding rapidly. I want to move smoothly to the third theme here, taking Ebola as a link, and that is emergencies. Now this picture about investing in emergencies tells a variety of stories, but I really want to focus on just one story, and that's the amount of money that was spent in responding to Ebola and how that money was spent. So the amount of money spent, the amount of money pledged for the Ebola response was a massive $9 billion because the rich world felt that it was seriously under threat. Now, because the response was relatively slow, it came relatively late. The amount that was needed to contain the response, in other words, the amount that was needed to contain the epidemic in the first instance, was around about $5 billion. $5 billion was pledged, but $5 billion was also stumped up as well. So the rich world paid about $5 billion in order to fund the necessary response. But the reason it cost so much is because the response was arguably rather slow. If we had a faster response to Ebola, then we could have got away with investing less. The second set of bars is important in this as well. What happened in Ebola is that there was a big pledge also for sustainability, in other words, investing in the local response by local health services. And here, the pledges were far greater than the money that was actually invested. So there are a couple of questions that come out of this. One is, how could we actually have spent less in the first place containing the response? And secondly, if we're going to spend a large amount of money, why not spend it in the countries that are at risk, strengthening the response systems in those countries? And so a great deal of thinking has gone into how to address those questions, and I'll just tell you about one strand of thinking, in part because it's been rather controversial in the field. And that is, if there's not enough money in the public sector, basically, how could we get the private sector involved? Now, this makes people in public health extremely nervous because there is a widely held view, World Health Organization, many other organizations, that global health is a global public good, and the private sector doesn't and shouldn't have a role in it. But other people have been thinking somewhat differently about it, partly because the amount of money that's needed is absolutely huge. I've just been talking to you about billions of dollars. So who's going to stump up very large amounts of money? The question is, how could we persuade private investors to get involved? So one scheme that's recently emerged, that I'll show you in a moment, really has its roots in thinking around insurance for catastrophes. For example, around hurricanes like Hurricane Andrew, that hit the coast of Florida on the 24th of August, 1992. And the thinking began to embrace thinking in the private sector. And an account of this, an excellent account of this, is by Michael Lewis in his article, Nature's Casino, where he points out that Wall Street is a machine for turning information nobody cares about into information that people could get rich from. So how can you do that with respect to epidemics, for example? Well, one scheme that's been produced by the World Bank, working with insurance and reinsurance companies, and also with WHO in risk assessment, is this scheme here, the so-called Pandemic Emergency Financing Facility. And the aim of this is to create a very large pot of money that would be fed by private investors who've got the billions of dollars to spend on this. But how can you get them involved? Well, the way in getting them involved is to persuade the investors that if they put the money in a pot, investors down here, pot in the middle, they could effectively bet against an epidemic taking place. So what you do is you get the insurance companies essentially to use the money to insure countries against an epidemic taking place. So if there's no epidemic, the investors win. They get their money back, but they also earn interest on their investment. If there is an outbreak, then they lose all their money. So who's willing to bet? And what would the insurance premiums be? Well, at the moment, the scheme is up and running. It's run by the World Bank. But to my taste, the insurance premiums that come out of this look pretty high. Countries are being offered a one-stop payout of $500 billion, but the beauty is that they would get it instantly. Rather than having to wait several months to an epidemic to unfold, they would get the payout instantly. But the insurance premium that they're going to have to pay is something like $50 million a year for 3 years. And that sounds pretty steep to me. So I think we have to wait to see how much uptake there is. But I think these sorts of ideas are really ideas about how you manage risk, and novel ideas about how to manage risk are increasingly welcome. Let me turn to climate change, the next topic that I wanted to talk about. You'll remember recently the launch of the 1.5 degrees centigrade report. That's reflected in this newspaper report. Actually, The Guardian was the only newspaper that carried this on its front page. In all other media, it was buried in the middle. And we had a couple of commentators, both of whom have spoken here in recent weeks or months. Christiana Figueres, who gave a super talk over at the Sheldonian Theatre, said at the time, limiting warming to 1.5 degrees centigrade is possible if there is political will. Well, that's the big if. Will there be the political will? And Nick Stern also said at the time, this was inside the pages of The Guardian, all leaders must recognise the choice. Act decisively now or suffer the consequences later. Well, you can probably make a mental list of world leaders and make an educated guess about how they would choose in response to that. The problem is that whilst politicians are very keen to talk about our children's children, giving the sense that they're thinking about the long term, they're actually largely thinking about the short term. And the inconvenient truths about investing in climate change is that basically, in many people's perceptions, still the cost of climate action exceeds the benefits, including the health benefits, that will come from that action. And I've grouped the argument in 3 points here. First of all, there are large and continuing immediate benefits from not taking any action. Witness the debate in this country at the moment about fracking in the north of England. The costs, on the other hand, are perceived to be relatively small. The health community will talk about hundreds of thousands of lives that may be lost, but that's hundreds of thousands of lives as against 60 million people who die each year. It's a relatively small quantity, and those lives will be lost in the future. And the future is going to be discounted, as indicated here, and as I indicated before, the future is not as valuable as the present, and everyone is considering the probability of whether these threats that appear in the climate change media are actually going to be made manifest. There's uncertainty, in other words, about the risk of what, when, where, and who is going to happen. And both of those things disincline people to act in the present. So what can we do about those things? I want to make 4 quick comments. First of all, the value of not taking action, or the threat of not taking action, is clearly rising from one week to the next. Hardly a day goes by without something appears in the media about the costs of climate change. And clearly public opinion is moving. The question is whether it's moving fast enough. At Davos, we had Greta Thunberg's memorable, "I want you to panic." And in the scientific literature, we've had some more subtle analyses. This is Science last week on the strengthened scientific support for the so-called endangerment finding, which quantifies the risk to health and other aspects of greenhouse gas emissions. And we've got everything in between, indicated by these other reports here. Incidentally, I personally thought the Hindu Kush Himalaya assessment was actually terrifying among the things that have appeared in the climate change literature recently. So in terms of valuing the future and valuing what we do and the need for action, clearly the needle is moving. But what else can we do? Well, one striking thing about panic at Davos, many of you may, looking at Davos on TV, think that Davos is not typically a place where people panic. But there are some interesting statistics that come out of the World Economic Forum each year. One of them is the global risks landscape, and I've redrawn the picture in the report that the World Economic Forum prepared in advance of this year's Davos conference. What they do is they ask business leaders, what do you think are the biggest threats in the world, assessed in terms of the likelihood that they'll happen and the impact if they do happen. 2 parameters in the analysis that I've been talking about. And these are the data points, and I've just highlighted a few of them. Most likely to happen, biggest impact, extreme weather events, the failure of the climate response, natural disasters, water crises, man-made environment disasters. Some of the things that I've just been talking about. But what's interesting about this, above and beyond what I've just said about moving the needle, is that in the context of public health, the business community is rather sensitive to the idea of uncertainty and change. And in my experience, there has been a strong response to threats that can happen suddenly, like Ebola, as distinct from threats that are there all the time, but much bigger. I spent years working on tuberculosis in the World Health Organization. TB kills about 1.5 million people every year, but nobody cares about that because it killed 1.5 million last year, this year, next year, and the year after that. Everybody knows where tuberculosis sits and who is at risk. But as soon as you introduce uncertainty and threat, as around Ebola, then people respond, and they can respond big. Now, I don't know, actually, whether this means, from the business perspective, that this is going to be good for investment in health or bad for investment in health, but it is certainly a phenomenon. Uncertainty and risk are important. The next point is about, essentially, what are called co-benefits. If you don't think that greenhouse gases are important, then align it with other things that are important. So greenhouse gases linked with air pollution have become a prominent part of the argument for public health because they come from the same sources in many instances. These are some of the statistics about air pollution. Incidentally, this picture was actually taken from the Bryan Adams concert in Delhi towards the end of the year, last year, where he projected his own shadow from the stage, which is here, onto a cloud of pollution in the background so that his shadow could be seen by the hundreds of thousands of people who were attending the concert. The important thing, though, is that the co-benefits are potentially large of acting against air pollution. One of the most astonishing statistics that's emerged in public health in recent years is that air pollution is responsible for about 6 to 7 million deaths per year. So remember, I told you about 60 million people die each year. So 1 in 10 people are dying from events that are related to air pollution. That is astonishing from a public health point of view. The problem is, it's not particularly astonishing from the perspective of individual risk. Because let's say there are 6 or 7 billion people in the world. So the percentage of all deaths is about 10%, but the risk to any one individual is about 0.1%. So it's 100 times lower. And what we're asking people to do is to change their behavior. And people are making a judgment about that based on the 0.1% and not on the basis of the 10%. So the argument around 10% strengthens our hand, but it may not do as much as we want it to change people's behavior. And the last question about climate change is, who thinks the future is likely to be most important? Well, we are sometimes inclined to put our trust in governments, and we regard industry as the enemy. But actually, industry is thinking for the long term with regard to climate change on a much longer time scale than government is. And this is a comment that was made by the chief executive of Shell recently, who said, talking to UK government, Shell would support the UK bringing forward the petrol ban from 2040. So this is the chief executive of Shell asking for an earlier petrol ban and introducing that ban sooner. That runs counter to what you'd expect, but there's an extremely good reason for that, of course. They want to know what cars are running on, not in 3 years' time or 5 years' time. They want to know what cars they're building in 20 years' time and 30 years' time. So the perspective of industry is far longer. And these are the people who care most about the future. So it's partly a question about asking where you can get most leverage in this debate. Finally, I'm going to come to sanitation. And I don't know how much time I've got left, 5 minutes. Let me come in the last 5 minutes to sanitation where I started. As was pointed out in an editorial in Nature Microbiology towards the end of last year, actually this is World Toilet Day, 19th of November, date for your diaries this year, we need to talk about crapping. Well, we do. The question is, how should we talk about crapping? A lot of the conversation is essential, but it's not sufficient. My colleagues in WHO have called for increased investment in toilets. Well, investment is only part of the problem. In fact, there's already a lot of investment in toilets. Bill Gates, top right, you may not be able to read the caption, but Bill Gates is very concerned about why the world deserves a better toilet. So this is partly about monetary investment, and it's partly about technology, but it's by no means all about that. And let me just show you one important example, which brings me back to open defecation in India and why that continues at the moment. The contrast here between India and Bangladesh is interesting and important. Bangladesh has essentially eradicated open defecation. India has not done so. And that's partly because of cultural and religious differences between the two countries. So the data on open defecation, Bangladesh, 0, India, very substantial. There's actually a difference in the use of treatment as well, but that's a somewhat different story. Let me come very quickly to the conclusion about India. The problem is this. WHO and others have felt that what's really important is to have an affordable latrine that people can use. The problem is that the affordable, cheap and efficient latrine is actually one that has to be emptied manually. And in Hindu culture, manual emptying of latrines is typically done by Dalits or untouchables. So what people do in private, of course, is that they don't use Dalits to empty their pit latrines. What they do is they don't empty them at all. They actually buy a more expensive latrine that can be emptied by machine or not emptied at all, or they continue to defecate openly. And unless you understand this fact, it doesn't matter how much you invest in toilets, it doesn't matter how good the technology is, people won't use them unless you address these cultural and social values that are extremely important and a fundamental source of the persistence of diarrheal disease and the relatively high death rate from diarrheal disease in India. So this is my final picture, which attempts to bring together what I've said. So I'm not going to read the summary at the bottom there, you can look at it if you want. I just want to bring out a couple of the major points behind what I've said in addressing the question of why do we spend so little on prevention? Well, the first part of the question is, do we really spend so little on prevention? I think we probably do, but the problem is that we don't have good enough data. In terms of investment, we're really guided by the International System of Health Accounts, which is really a superb system for what it intends to do. But it's not enough for the environment that we're presently working in. If we want, as suggested by the Sustainable Development Goals, to look at root causes and investment in root causes, then the system of health accounts doesn't cover the story at all. We're going to have to do something different. I have some thoughts about what, but I don't have time to tell you about them now. The key point is the subtitle of this slide, if you like. I think in investigating prevention, we've resorted a great deal to standard but useful economic evaluations that have told us about the returns on investment, the cost effectiveness, the cost benefit analysis of investing in prevention. But what fundamentally we need to understand, going beyond that, is how people make choices actually in practice. And I think there's been far too little investment in that. So my null hypothesis, if you like, is that the choices that are made on prevention versus treatment are largely rational choices. They're rational choices made in the context of the perception of the future risk to health, and as judged by those who have the power to choose, whoever they may be. So this is a call, in a way, for a much more investigation into how people really choose to invest in prevention rather than cure. Thanks for listening.
Chris, thank you very, very much indeed for a wonderfully clear and thought-provoking presentation. We've now got plenty of time for questions, I'm glad to say. Clara at the back has a mic, which I will ask her to bring around. But before you speak, do remember that this talk is being filmed and live webcast. So if you don't want to be filmed or live webcast, perhaps save your question for in private later. So there was a question, was it right here? Okay, will you wait for the mic because of the webcast, please?
Sorry, could you pass that down?
Hi, Marcus Harker, Harvard School of Public Health. I want to take you up on one of your last questions, which is, do we really invest so little in prevention? Much of health prevention takes place in the sphere of education, regulation, or safe water, which would also not appear in the health accounts, and you have not captured any of such spending or the implied cost of regulation in your discussion.
Yep. Yeah, it's a very good point, and it's a weakness, as I said, of the system of health accounts that are used at the moment. And ideally, we would have a systematic way of measuring how much is truly invested in deep prevention, if you like, in the sectors that you've mentioned. We don't have that at the moment, but what we do have is a series of specific studies. We have specific studies on water and sanitation, for example. We have specific studies on climate change. And those studies are done in different ways for different purposes, but they are a useful guide. My reading of those studies is that they still suggest that we spend too little on prevention, or at least acknowledging that there's probably a rational choice for that. Understanding that better would give us a better handle on how we understand ways in which we could invest more. One thing on water and sanitation, for example, that's very important, and I've discovered only relatively recently, is actually water and sanitation people don't really think of health as an outcome of what they do. It's largely a development issue. And there's a lot of water and sanitation engineering that is done almost irrespective of the health benefits or the health consequences of it. So there's a real need for a meeting of minds across different disciplines there, including health in the way in which water and sanitation is done.
Question two-thirds of the way.
Thank you. I'm Brenda Bourbon from the Environmental Change Institute, and I want to refer to a situation in this country We have in the last winter, 50,000 people died from excess winter deaths, linked to the problem of fuel poverty, linked to the problem of being cold in their own homes.
Yep.
But if you talk to the National Health Service, as I've tried, about how to intervene, they are not interested at all in the capital investment of prevention when it comes to making people's homes more energy efficient and therefore warmer. So we've got the situation where somebody gets ill, gets sent to hospital, COPD or respiratory or whatever. The medics spend a lot of money making them better and send them back to the conditions that made them ill.
Yep.
And I don't see how to get round it.
Yeah, well, that's one example of many. So from an economics and an analytical perspective, then one would ask the obvious questions such as, if you invested in better housing for people, what would be the benefits in addition to, of course, saving lives from people dying of cold? There are going to be many other benefits, and those analyses clearly need to be done. But I think the other key question in this is, how are politicians making their choices and making their decisions? What is the criteria that they are using? Because there probably are criteria. I have often found, working with government, that there are criteria that are being used, and I've been surprised about what those criteria are. But if you understand what they are, then you have beginnings of a debate and a discussion about how to make things better. I don't know whether it's going to work in your particular instance, but in general, it's not just the formal economic analysis that's important, it's understanding how the choices and decisions are going to be made.
George Smith from Healthwatch, Oxfordshire. A quick comment and a question. The comment, fragmentation. The problem in this country is that the different aspects of this are severely fragmented. Playing fields are looked after by parish councils, sports and health centres by district council, home improvements by district councils, support for elderly people and child mental health is local authority, air pollution is Department of the Environment, the water system has been privatised, and you've got a split between social services, community support and the NHS. So it's very difficult bringing together. The other side of this, the insurance, can I pick up your point on insurance? I'm familiar, being an engineer by training, I'm familiar with large jet engine companies. And the business model is interesting there. Traditionally, they sold engines fairly cheap and made a fortune on repairing and servicing them. They changed the business model to provide a total package, and this completely changed their own internal strategy to R&D. Their internal strategy now was to prevent the thing ever going wrong. So they made more money by making a more reliable product. In the health area, the interesting thing is companies that provide medical services under an insurance-based scheme. It seems to me that potentially they have the greatest incentive to focus on prevention, but I'm not sure that that actually happens in practice.
Yeah, well, let me just make a couple of comments in that regard. You've actually said many interesting things there, but you used the term business model, and I think broadly defined, we need to think more carefully about what the business model is for prevention. And by that I mean not necessarily getting the private sector to invest, which was one of the examples that I gave, but what is the logic of the argument for prevention and who is susceptible to that logic? And that's where I think there hasn't been enough thinking done. In the resort to standard methods and economic evaluation, I think there hasn't been enough thought given to that business model generally understood. But your points are well taken.
Sorry, at the back, please.
I think a lot of the problems you mentioned are due to overpopulation. That's just one point. The other point is, how does one overcome superstition? I gather, talking about talking about crapping outdoors, I gather the government of India encouraged the provision of toilets inside houses, but since people think it's unhygienic there to use them, that's why they use them outside. Well, how do you overcome that superstition?
On the first thing, overpopulation, you could make the argument that there are too many people and there are consequences for that. I think what has to immediately follow from that is what in practice do you think is caused by that? What are the consequences of that? And in practice, what is your proposal for managing an environment where there are many people? And of course, there are many problems associated with that. I mean, just very briefly, one of the problems in sanitation actually is that you can do some of these things on a small scale where you have a close-knit community where people feel responsible for each other's well-being, but it's sometimes very hard to take them to the scale of a very large city with very large numbers of people, which are not so socially integrated. So that's one facet, but you need to understand what the specifics of the problem are under those circumstances. You used the word superstition, and I wouldn't use that word. I would think about what are the social, cultural, behavioural values around sanitation. Clearly, toilet culture is extremely sensitive, and that degree of sensitivity has often been overlooked. And the reason, and because it's been overlooked, then there have been many failures in that regard, like the ones that I pointed to. But when you work with individual communities and you understand what their concerns are, then often you have a route into solving that problem. I think there's a way, in other words, of actually emptying pit latrines that would be beneficial for everybody. But you have to understand what the nature of the problem is at first. And it should not be labelled as a superstition.
You at the front?
Hello, my name is Nicholas Tresillian, and I'm an art historian, but also a one-time keeper of rare breed pigs. And in that process, I discovered the great international crime that has been going on for many years now. That we are feeding our farmers and industries in general are feeding our food animals with antibiotics in order to keep down vet spills and order to improve the rate of growth. Now, I don't know how far in the civilized world this goes. I know it goes very far in Europe. And I wonder where that fits into your general picture of prevention in your wonderful talk.
Yeah, thank you. Well, the point about overuse of antibiotics in livestock has been made frequently, and I think there's been some problems in this area are quite intractable. There has been really a significant progress. So farmers are discovering very widely, big farmers, chicken farmers, cattle, and so on, that actually the antibiotics that they have traditionally used don't need to be used anymore. And by withdrawing them, there's no loss of productivity. And so they've basically agreed to do it. So that is looking like a success. It won't be so easy everywhere, but that is a success in reducing antibiotics and therefore reducing the risk of antibiotic resistance.
Hi, Tom Rowland. I'm a medical student here. You mentioned in your talk that one of the arguments against action on climate change is discounting the future years, the benefits. What's the logic behind that discounting? Why do we discount 10 years' time from today?
Yeah, that's an interesting question, and there's a big literature on that as well. Usually the simple-minded economic answer, I don't mean to say economists are simple-minded anyway, but the simple answer to that is that if you were to take money that you've got today and invest it in something else, then the value of that money will grow through time. If you don't invest it in that, you're essentially losing that money. So part of the argument is about lost revenue in future. But the psychologists will say it's actually not that simple, because people actually have what is been called a pure time preference. In other words, people intrinsically, for whatever reasons, perhaps through evolutionary time, I don't know, it's not my area, but people have intrinsically a preference for valuing the present as distinct from the future, and that's aside from economic arguments. There's also a literature on the way in which people discount those benefits. If they're smokers, for example, how do they view their risk of death going into in the future? And there's a big and interesting literature around that as well. But the bottom line is people don't value the future as much as they value the present. What's done as standard in economic evaluation is that you use a standard discount rate like 3% or 4%, which is usually guided by the rate at which you can make money on investment in US government bonds or something like that. But actually, the way in which people make a judgment about discount rate, and the person sitting next to you is an expert on this, Marcus, it's part of his body of work. The way in which people make choices about discount rates actually varies from one set of circumstances to another. And I'm actually much more interested in the way in which people choose to discount the future depending on their particular circumstances than the standard arguments for discount rates.
Yes, yeah.
And we are told that in the Garden of Eden everything was lovely. The idea has been picked up by, I think it's James Lovelock, is it, with the Gaia idea. Basically, the planet can look after itself fairly well, and one of the things we've been doing through the millennia is overpopulating it, point mentioned over here. There are international meetings on how to reduce climate change, etc. But why not really push reducing the world population? Because you'll reduce the pollution problems, you'll reduce so many problems, to put it very simply.
Yeah. Well, there are many people who think that there are too many of us on this planet. But the practical question is, how do you manage population size on the planet for everybody's well-being? Let's face it, for everybody's well-being. And it's not so long that was discovered, it's taken for granted now in public health, but it's actually within the last 2 decades that there have been some very profound discoveries on this. And one of them is that if you prevent young children from dying, for example, from diarrheal diseases in the way that I described, then women tend to have fewer children. So fertility falls as a matter of choice and as a matter of preference for benefit as a consequence of ensuring that children's lives will be longer than they have traditionally been in the past. I think it's those processes that we need to understand better when we're thinking about demographic change in populations. I think that the notion that you can force a lower birth rate, I think most people would agree that that's really a non-starter. It doesn't work, even if you had a government policy to do it. It's often pointed out that Italy is the most Catholic country in Europe and it has the lowest fertility rate, despite what the Catholic Church would like to urge upon it.
But China's done it, India's done it in the past.
Yeah, and it hasn't been
So
as
this is something for us
successful.
to discuss later, which will be lovely. I'm going to call an end here, but not before. First of all, I have the last word. Chris, you used 2 words that I have to disagree with. Do you know what they were? Enough zoology.
Enough zoology.
Secondly, I wanted to tell you all that on the 5th of March, there are 2 more infectious disease talks, one at lunchtime from Moritz Kramer on maps of the spread of infection, and one at this time from Alberto Jubilini on the ethics of vaccination. So look them up on the website, do come along, it's great to have so many of you here. And thirdly, not the last, but third, do please join us for drinks next door right now. But of course, most importantly, let's all thank Chris for a wonderful talk.